Let's do the study guide review first. So let's just review the material quick. 3 types of cartilage. Hyaline, fibrous, elastic. Properties. Hyaline is sort of jack of all trades, right? Fibrous is resilient to the pressure, extremely resilient to the pressure. Elastic is elastic. Fiber cartilage is found in the places with extreme compression forces, meaning vertebral column, pubic symphysis. Elastic cartilage is in the ear and epiglottis. Hyaline cartilage is practically everywhere else, also comprises articular cartilage. Structural difference to help them perform their functions. Now, this is something I want to mention. So, elastic cartilage, elastin, right? Fiber cartilage, thick collagen fibers. Those thick fibers is what enables it to resist the compression forces. Does that make sense? We kind of covered where you can find those types of cartilage. Think about how location is linked to their functions. Okay? Outermost layer of the cartilage, perichondrium, is perichondrium vascularized. Perichondrium may contain some blood vessels. Matrix of the cartilage doesn't. What type of tissue? Connective tissue. Inner layer of the cartilage, matrix with chondrocytes. Is it vascularized? No. Absolutely no. Consists of matrix, ground substance, the protein-rich substance, and chondrocytes. So far, do you follow? Awesome. Oppositional growth of cartilage. When cells next to the perichondrium, chondroblasts, next to the perichondrium, add new cartilage next to the perichondrium, essentially making it thicker. Interstitial growth. Now this time, chondrocytes and chondroblasts inside of the matrix produce the matrix, so the cartilage essentially grows in all directions. Okay? And another important feature of interstitial growth, chondroblasts divide inside of the matrix. So there are more chondroblasts that produce more matrix. What is the importance of cartilage growth in relation to the bone growth? Can anyone tell me? Can bone grow without cartilage growth? No. Because, well, interstitially, no. It can remodel without cartilage involvement. But interstitial growth, the elongation of the bone, is impossible without the cartilage growth. Okay? Can cartilage become a bone? No. But can it become hardened? Can it become calcified? It can. So saturation of cartilaginous tissue with hydroxyapatite. Difference between axial and appendicular skeleton. Axial is what are the parts of axial skeleton? Skull and vertebrae. Appendicular skeleton, everything else. Yeah, so 2 girdles and limbs. Features of the long bone. So how do you distinguish? There will be questions. Long versus short versus flat versus irregular. Few words. Frontal. Short, flat, long, irregular. Frontal. flat. It is flat bone. Mandible, irregular. Ribs, humerus, patella, phalanges, carpals, short. All carpals, pretty much. Let me give you the list. All bones of the limbs except carpals and tarsals are long. Does that make sense? All bones of the limbs except carpals and tarsals are long. Short bones, patellar bones, carpals and tarsals. Irregular bones, all vertebrae, coxal bones, mandible, majority of the facial bones. We talk maxilla, palatine bone, zygomatic bone. They're going to be regular bones. Bones of the cranium are flat bones. Clavicle is considered a flat bone. Ribs and sternum are flat bones. Yes?
Maybe a stupid question.
No, it's not as stupid.
Why don't we categorize the teeth? Would those be considered short bones?
They're not bones.
Oh, really?
They're not really bones because the tissue that they consist of, so they have enamel on the outside, then they have dentin, then they have pulp. So structurally, they are very different from either spongy or compact bone. They sort of structure themselves. So calcium in the form of hydroxyapatite is an important component of enamel and dentin. But if you would look at the microstructure of the teeth, of a tooth, it's totally different from the bone, just absolutely different. Okay? So you're going to get a question, such and such bone is. You have to pick one of the answers. Pretty simple. I'm not going to try to trip you. Okay? Bone functions. Be reasonable, okay? So it's not like a storage site for protein, for instance, or a storage site for glucose. Movement support, hormone production, storage of fat, storage of minerals, hemopoiesis. Do you understand what word hemopoiesis means? Blood production, yes. As a general rule, I always welcome you during the exam. If you don't understand what the word means, come and ask. If that word was in the study guide and there was a specific question, what is specific term, and you don't know that, I cannot help with it. But if it wasn't on a study guide and I mentioned it a couple of times and you kind of struggle with it, I'll help you out. So that pretty much explains it. What are the growth arrest lines? When are they formed, growth arrest lines? Malnutrition or? Yeah, disease, any sort of moment when you stop growing, yes. Macroscopic features of compact bone. I want to do another run for... No, it's not going to be a successful run. I wanted to see if I have that disarticulated cut across compact bone. Well, anyway, let's presume we have a longitudinal section here. Those ends of the compact bone are epiphysis, diaphysis, inside of the diaphysis, in there. What is in there? A cavity, medullary cavity. Inside of the medullary cavity in children is red bone marrow. In adults, it's usually yellow. Epiphysis are filled with spongy bone. On the outside, it's compact. The outside surface of any bone is covered with Compact bone, but on the surface of the compact bone is periosteum. All the inner surfaces are covered with endosteum. What's the difference between endosteum and periosteum? If it's inside, does it experience any significant forces? No. So endosteum is delicate tissue. It's pretty much loose connective tissue. Periosteum is dense, irregular connective tissue which attaches ligaments to the bone. So it does experience strong pulling forces. Okay? Ends of the bones are often covered with articulating ends are covered with cartilage, articular cartilage. And if you will cut the epiphysis, the little line in the epiphysis represents what? It's epiphyseal plate. In children, it's epiphyseal growth line. In adults, when it ossifies, it's just epiphyseal plate. Difference between spongy and compact. Spongy bone consists of like lattices, right? Macroscopically, compact bone is much more dense. Compact bone is always on the outside. Spongy is inside. The difference between the long bone and other types. So long bone will be something like this. Okay? So you have a cavity inside, you have compact bone, the spongy bone and spongy bone and compact bone on the outside, right? In case of the flat bone or short bone or irregular bone, outside is composed of compact. In between you're going to find spongy, right? Any cavity? What's inside of that spongy bone? Bone marrow. So outer surfaces are covered with periosteum. Inner surfaces and trabeculae are covered with endosteum. Now, I'm going to ask you, and you tell me, since we just covered. Diaphysis, any questions? Epiphysis, medullary cavity, articular surface, epiphyseal line. What are Sharpie's fibers? Attach periosteum to the bone. Yellow bone marrow, fat. Red bone marrow, hemopoietic organ that produces blood. Mechanism for the shin splints, we talked about it. What's the mechanism for shin splints? Periostitis. What detaches from the bone surface? Periosteum detaches from the surface of the compact bone. That is periostitis. Sharpie's fibers they break, and periosteum detaches. Which bones have more bone marrow, kids or adults? Kids. Because in kids, medullary cavities are filled with bone marrow. And of course, we never talk about absolute amount. We talk about relative. Projections. So, for projections, you want, first of all, there will be anatomical questions, like find the greater trochanter. So here's the greater trochanter. Find, the greater tubercle. Here's the greater tubercle. Find the smaller tubercle. Lesser tubercle. That's lesser tubercle. What you need to understand. Remember the question in the quiz. Nerve will most likely go through. You have to understand the difference, functional difference, between, say, foramina and crest. If I ask you, muscle is most likely attached to the, it's going to be projection, not opening. Okay, so in the list of like canal, sulcus, foramina, and crest, muscle will be attached to the crest because all others are either depressions or projections. Am I clear about this particular question? We good? Moving on. Functions of the osteogenic stem cells. They become osteoblasts. Can they divide? Yes. Where can they be found? Yeah, pretty much periosteal, the edge between, periosteum and the bone itself. Functions of the osteoblasts. They produce bone matrix, differentiate into osteocytes, so you can say stem blasts sites. Okay? Can they divide? No. They can be found inside of the bone, whether it's compact or trabecular. Osteocytes, what is their function? Maintenance of the matrix. Yes, they don't make a lot, it just maintain the integrity. What do they differentiate into? They don't differentiate. They're like terminally differentiated. Okay? Can they divide? No. They can be found in lacunae of compact or trabecular bone. Bone lining cells. We don't really know. Maybe maintenance of the matrix. Again, can they divide? Yeah, well, probably no. We presume that they're old osteoblasts, but kind of weird. They're weird cells. Where they can be found, bone lining. What are the functions of osteoclasts? Destroy all the bone. Can they divide? No, absolutely not. They're terminally differentiated. Where can they be found? Bone surface. They can be found in both between bone and periosteum, bone and endosteum. Bone surface. Where do they come from? When I say so, where do they come from? What are the cells that give rise to osteoclasts? Hematopoietic, yes. Simpler. Macrophages. Cells. Question. The word macrophage throws you off? Okay. Lost in the cell functions? Okay. So osteoclasts. What do they do? What do they do? Osteoclasts. They destroy the bone. All other cells make new bone. These guys destroy it. Is that clear? Do they belong to the same family as osteoblasts or osteocytes or osteogenic stem cells? Do they or do they not? No. They not. Okay? So if they don't belong to that family, which family they belong to then? Huh? Macrophages. They are phagocytic cells. Do you understand the word phagocyte? So they are eating the bone. Is that clear? Better? Good. Yes?
I just want to clarify specifically the bone lining cells. Are we determining if they are inactive?
They are inactive. They are inactive. Considered are inactive. And, for those of you who watches Game of Thrones, You can think about bone cells as the Stark family, and osteoclasts, like that guy that I totally forgot his name. The guy that got castrated eventually.
It's terrible.
Yeah, but he was like from the different family, but lived with Starks. Okay,
Was it the ginger guy? Was he redheaded?
maybe.
I don't see it.
It's all like very, very grayish, so it's hard to say the colors. So they do not belong to the same lineage. They do not belong to the same family. They belong to a different family of cells. Okay? The osteoclasts. Elementary building blocks of compact bone. How do we call them? Elementary building blocks, the compact bone. Osteons. I always have a problem with the question, like, what is the central canal? It's a goddamn canal. It's an opening. Okay, what does it contain? Nerves and blood vessels. Perforating canals, what does they function? Connect the central canals. Look at this model. So those are central canals. Those are perforating canals. So if these are like A, B, C, D, E streets, those are numbered streets. Okay? Lamellae. What are the lamellae? Lamellae are concentric. Go ahead. Yeah, concentric tubes of the matrix that compose osteon. What makes them resistant to twisting?
They go like this.
Directions of collagen fibers. Collagen fibers are directed in different directions. Lacunae. What are the lacunae? Yep, cavities. Inside of them are osteocytes. Those lacunae with osteocytes are connected by canaliculi. Canaliculi are formed when osteocytes become trapped in matrix, and the projections of osteocytes become trapped in matrix, and this forms lacunae. So those are, you can see osteocytes here, and you can see lacunae as little empty pockets. Interstitial and circumferential lamellae. Remember, interstitial lamellae are remnants of the old osteons. Circumferential ones, these guys. What is the function, or what are the functions of interstitial lamellae, circumferential lamellae? They run all around the bone. They make the bone resistant to.
Isn't that the pressure from this one?
Twisting. Because if you would look at circumferential lamellae here, the directions of collagen fibers are at an angle. That makes sense? So that adds another layer of protection against twisting forces. Does the spongy bone have osteons? No. But does it have lamellae? Yes. Does it have lacunae?
No.
Yes. It has everything except for the canal system. Look at this. This is compact bone, okay? So this is central canal. Does that make sense? And those are lamellae. Am I clear? This is spongy bone. So this is lamellae, this is lamellae, this is lamellae. There is no central canal. So they still form those concentric structures, but if the compact bone consists of multiple concentric structures, okay, like this osteons in a compact bone, each of those tiny lattices, if you cut it across, it's going to consist of several concentric lamellae. Do that make sense? So this, what I pictured here, is one projection of the trabecular bone, one trabeculae. Okay, so still you have lacunae, you have canaliculi, okay? What is located between the trabecula of the spongy bone? Bone marrow. Kind of checking on you. Chemical composition of the bone. Now, don't get crazy about chemical composition, okay? I mean, I'm not going to ask some chemical formulas like what's the formula of hydroxyapatite, okay? Osteoid, it not dies, it does. Osteoid, what does it consist of? Mainly, which biological molecule? Osteoid. Osteoid is a chemical. It's a matrix. What does it consist of? Collagen, wait till calcium. Collagen and proteins, other proteins. Pretty much it's a protein substance. What makes it so? Collagen is the main component of the osteoid. Okay? Do you follow me? Think about this. You have those collagen fibers, and in between them, there are proteins. Collagen fibers, what are they connected by? Sacrificial bonds, right? What's the function of these bones? They're supposed to break. So when bone experiences certain forces, okay, those fibers break and they sort of use the energy, they dissipate the energy that would otherwise break the bone. Okay? Which mineral that makes the bone hard? It's hydroxyapatite. What is the ion that's most important for the bone toughness and strength? Calcium. Okay. What is stored in the bone? You cannot go wrong. Huh?
Everything.
Well, like iron isn't, but you can see the main ions. So we're talking calcium, sodium, potassium, magnesium. Those are cations. Anions, we're talking phosphate, we're talking carbonate, and we're talking sulfate. Okay? And if you would look at human electrolyte balance, those are the essential ones, really. Okay? Of course, you do not need to know the percentages, and I will not ask you to pick the right list. Do you understand? Gold is not stored in the bone. Gold. By the way, one of the dangers of lead poisoning is that lead structurally is fairly similar to calcium, can get incorporated in the bone. It can, during metabolic processes, it can be deposited in the bone. One of the main problems with the strontium, you may have heard strontium poisoning, it's a radioactive element that can be found in the radioactive fallout after the nuclear explosion. Strontium is as close to calcium as one can be. It easily substitutes calcium in the bones, and you become, it never gets out of the bones. So you become radioactive till the end of your days. Kind of sucks. Ossification. Connective tissue, whether it's the fibrous connective tissue and the membrane or cartilage. Connective tissue is replaced by the bone, not converted, replaced. Okay? What drives it? Hormones. Two different types of it, endochondral and intermembranous. For endochondral ossification, what you need to know is, what does it start with? Primary ossification center. It is formed in where? Diaphysis, right? Develops into the medullary cavity and the bone collar. Then periosteal bud penetrates the bone collar and leads to the vascularization of medullary cavity. Is everyone comfortable with the word vascularization? Okay? Blood vessels develop. Secondary ossification centers are in the epiphysis, and once the ossification completes, cartilage, that long bone, where can it be found?
So once it's complete.
Ossification is done. There's still cartilage left. Where?
On the epiphysis.
Epiphyseal growth plates and articular cartilage, right? So articular cartilage and the cartilage in the epiphyseal growth plate. We good? Intramembranous ossification. You have a membrane, connective tissue membrane. Starts with an ossification center, the front of osteoblasts, produces matrix and spreads outwards. It's matrix. Some of the osteoblasts get trapped inside, become osteocytes. That make sense? So eventually you end up with a layer of trabecular bone and the outer layers of trabecular bone being remodeled to compact. Bones that are formed by intramembranous ossification are bones of the skull and clavicles. We good? Is that understood? That's all you need to know. Oh, you need to know that osteoblasts, when they become trapped, they become osteocytes. Two modes of the bone growth, appositional and interstitial. Now, it's slightly different from cartilage. Interstitial growth is responsible for making bone longer. Appositional is responsible for remodeling and thickening. Okay? So 5 zones responsible for the growth of the bone. If this is like, this is epiphysis, okay? And those are the lines. What's going to be the kind of closer to the end zone? Quiescent, right? Or resting zone. Then you have what? Proliferation. Then you have hypertrophy. Then you have calcification. And then you have ossification zone. Does that make sense? What happens in proliferation zone? Huh? Well, how? Growth can always happen in two ways. You can produce more cells, or cells can become larger. In proliferation zone, division of the chondroblasts. Go ahead.
Oh, okay. No, I just remembered the picture. So like once you get to the the calcifications, and that's where they get larger.
No, not yet. So this proliferation zone, chondrocytes and chondroblasts divide. Okay. In hypertrophy zone, they become hypertrophy, larger, essentially kind of eating up the matrix. In calcification zone, what happens to the cells? They die, and the matrix becomes calcified. And then in ossification zone, calcified matrix is replaced with the bone. What destroys calcified matrix? Which cells? Osteoclasts and osteoblasts deposit the new bone. Does interstitial growth stop? Yes. 20-ish. Okay. What's left? Which structure is left when interstitial growth stops? Epiphyseal plate. Go ahead.
So this, for the drawing up here, isn't this kind of the picture where that's in the slides where you have the smaller cells up top and then like bigger? Yeah, okay. I was just trying to picture it, but I couldn't.
Say again. That's exact. Yep, that's that. I just didn't separate, so it's not up to scale. I just wanted to show the order. Okay. Roles of hormones. Growth hormone. What's the function of growth hormone? Growth. Now, we're kind of peeking into AP2. That's, in my opinion, like best part of AP2. Endocrine, well, except for immunity, but that's a different story. Endocrine system. Growth hormone is responsible for growth all the time, all your life. When you sleep, it is produced. When you exercise, it is produced. So it's not because you're female or male, nothing about that. Testosterone. Growth, spurt during puberty, right? Also, testosterone is responsible for the maintenance of the bone density as well as estrogen. So we can kind of, put them together, okay? Why females are the higher risk for developing osteoporosis? Not just decrease, just tank. In males, testosterone levels decrease as well, but it's not that dramatic. Yeah, dramatic decrease, yes. Thyroid hormone. Protein synthesis, proper bone deposition proportions. Parathyroid hormone. What does it do? How does it affect the bone density by itself? Huh? How? Does it? The whole physiology is about increasing or decreasing. You have a parameter, you can have increase, decrease, or no effect. So parathyroid hormone, does it increase the bone density or decrease the bone density? Decreases. Yep. Decreases bone density. Calcitonin increases. I mean, we tell you that calcitonin increases the bone density. It kind of does, but concentrations are like, should be humongous. We still haven't fully understood the role of calcitonin in the bone metabolism. Parathyroid hormone is very clear. So its aim is to maintain the calcium levels in the blood. Okay? What is the first source of calcium in the body? Most convenient, abundant? Bones. Bones is the best source of calcium. So if you need calcium, in the blood, the first thing that's going to happen, bone resorption, right away. Does that make sense? What type of growth occurs in the remodeling? Oppositional. Which part of the bone becomes thicker? The wall, yeah. Bone wall in the diaphysis. Diaphysis becomes, not the whole thing diaphysis, the walls become thicker. Does that make sense? It's the walls, not the diaphysis itself. Bone diameter increases. The bone becomes a little heavier, but not too heavy. Bone remodeling, any projection. Does that make sense? Any projection. Look at this, that's a great example. You see that projection? This is called mastoid process. It's the site of attachment for several muscles that rotate your head. Scalenes and sternocleidomastoid muscles. They do this, they do this. If you think about the lever, it's a lousy lever. Okay? It's very mechanically disadvantageous lever. So those muscles are pretty strong, and by pulling on the bone, they pretty much produce that mastoid process. Does that make sense? That is, like if somebody wouldn't move the head ever, mastoid process would be practically non-existent. Does that make sense? Actually, one of the great examples of bone remodeling are jockeys. What is the hallmark anatomical feature of people who ride horses professionally? They're small because, a little digression, there's a lot of parents think if their kids are small, they need to play basketball and they will become taller. That's a complete and utter bullshit. Because the reason why everybody who plays basketball is tall, people who are small cannot play basketball on the same level of competition. Same reason for gymnastics. Gymnastics doesn't stop your growth. If you're 6 feet tall, you won't be able to compete to a regular gymnast just because of your height. You just won't be successful. That's it. So jockeys are small because they're light. If you weigh 250 pounds, you will break the poor horse back probably. They have bent legs because they always kind of use the legs to hug the horse. I don't know how to properly say it. A little bit bow-legged. That's pretty distinctive feature. Why are old bones more brittle? What makes bones brittle? Taking out calcium. What remodels the bone? Remember remodeling units. Each remodeling unit consists of what two types of bone cells? Osteoclasts and osteoblasts. Blasts. Deposition of matrix and destruction of the bone. So blasts responsible for deposition, clasts responsible for resorption. Osteoid seam is the layer of matrix, fresh matrix, that is deposited by osteoblasts during bone remodeling. Calcification front is pretty much the line that shows where osteoid becomes calcified. Questions? Moving nicely. Now.
Okay, so that's almost like laying down new cement.
Say again?
It's almost like laying down new cement.
Well, remodeling, yeah. You have okay, you put something new. When you put new kitchen, you remove the old one, okay, and you put new one in place. That's it. Osteoclast resorbs the bone. What you need to know that there are two components. Hydrochloric acid that destroys the calcium component. Well, not destroys, it dissolves the calcium component. Proteolytic enzymes, they degrade the protein component. Okay? What activates osteoclasts? The major activator. Parathyroid hormone. Okay? That's the main activator of osteoclasts. Another stimulus, of course, mechanical stimulus on the bone. And there's remodeling. What's more important, calcium or bone integrity? Calcium. Calcium homeostasis is the most important thing. How can you conserve calcium or deliver it in the body? What can you do to increase the calcium levels in the body?
Eat it.
You can eat it. Huh? It will increase the deposition to the bones, but if you don't eat enough, the bones will still become brittle. Always think about this. How can you increase your your disposable income? Two ways.
Save it or make more.
Earn more or spend less. Same goes for calcium. You either eat more calcium and absorb more from the intestine, okay? Or you excrete less. Excretion relates mostly to the kidneys. And of course, you can take calcium out of the bone, okay? When calcium is important because it regulates signal transmission. So if the levels are low, in general, what happens to muscular activity?
It decreases. Oh, it
Actually goes up. So which manifests in seizures, spasms, and irritability. If calcium levels are too high, that manifests in the muscle weakness, depression, and actually lead to coma.
They sleep more.
Hmm?
It's like, I'm trying to remember the chart. Like, so when you have too much, then the person sleeps more.
Yeah, it's pretty much the neuronal activity is depressed. What happens in the kidneys if calcium is too high? Kidney bones, kidney stones. Okay. Leptin regulates appetite. Okay. Role in the bone metabolism. Kind of answer this. The role of leptin in bone metabolism is controversial. Okay. Now, serotonin. The mood hormone, right? The good mood hormone. What does Prozac do? Anyone remembers?
It's an inhibitor.
Huh? It's inhibitor of serotonin, not serotonin. Serotonin, reuptake. Because think about this. Prozac makes you happy, I suppose. I don't know. But if it makes you happy, it needs to increase levels of serotonin in the synaptic cleft. How can it do it? You cannot inhibit diffusion. Serotonin is practically not degraded. So one thing you can do, you can inhibit its reuptake in the presynaptic neuron. Prozac does it. It inhibits the serotonin reuptake, which leads to the elevated levels of serotonin in the nervous system and in the blood. Serotonin stimulates osteoclasts, depresses osteoblasts. So what you end up with? Decreased bone density.
Is it true we have more serotonin like in our gut than
We have a ton of serotonin in the gut.
like, I don't know.
It's a neuropeptide. It regulates digestive activities in the stomach and in the intestine. It's really important.
So like how exactly are we gauging how much serotonin is?
We don't.
Because you can't do that unless the
Say it again?
You can't really, never mind. I can't.
How can you measure serotonin?
Yeah, there's more serotonin in your gut than in your head.
Yeah, but we can measure amount of serotonin in the blood or in the extracellular fluid in the tissues. Of course, it's not perfect. It's not like we have like a little dude that runs into the synaptic cleft and like counts the molecules of serotonin. But we can, mostly those studies look at, okay, what if we increase serotonin uptake? What if we decrease serotonin uptake? What's going to change? Regulation of bone remodeling. What you need to understand. Two things contribute. Well, three things contribute. One, mechanical stress guides the remodeling pattern. Okay? Calcium determines if the remodeling will occur at all. So if calcium levels are normal, there's going to be remodeling. If calcium levels are low, calcium comes first, remodeling comes second. Okay? Possible mechanisms that guide bone remodeling? Probably electrical signals. Hormones, they regulate bone remodeling. Oh God. If you don't have proper levels of growth hormone, thyroid hormone, parathyroid hormone, then bone remodeling is not going to be complete. Growth hormone regulates the bone growth, for God's sakes. Stimulates protein synthesis and cell metabolism and whatnot. Does that make sense? So pretty much the one phrase, the normal levels of hormones are necessary for proper bone remodeling. Fractures, displaced, non-displaced, ends are aligned, not aligned, complete, incomplete, completely broken, incompletely broken, open and closed fractures, penetration, no penetration, the skin. Are the classifications like, well, we mentioned it, comminuted fractures, crushed, epiphyseal line fractures, but I'm not going to focus too much on those other classifications. Main cause of fractures in youth, trauma, in elderly, compression, brittleness of the bones. Main treatment of fractures, reduction. Okay. Main stages of fracture repair, what you have to know. We have hematoma. Then we have fibrocartilaginous callus. Then we have bony callus. Okay. And then we have normal complete bone. Hematoma is formed because of the blood spillage from the torn blood vessels into the site of the fracture. Fibroblasts, what do? They deposit collagen and secrete matrix. Phagocytes, what do? Destroy debris and dead cells. Osteoblasts deposit matrix of the bone, slowly but steadily. So collagen in fibrocartilaginous callus brings the ends of the bones together. So what bone initially is formed at the site of the fracture? Spongy or compact? Spongy. And then on the outside, it is remodeled into the compact bone. Why does the repair bone have the same shape as the bone before the fracture? Same stress. Very good. Osteomalacia. Deficit of calcium. Osteomalacia is the name for the adult disease. Okay? Can deficit of any vitamin cause something like osteomalacia? Yeah. Vitamin D. Rickets. Same stuff, but in kids. What are the signs and features? I don't want very specific description. What happens? Bones are
They're kind of bent.
bend, they soft, that's why they bend, they malformed. That's all you got now. Osteoporosis.
You have more bone resorption than deposition.
Excellent. More bone resorption than depositions. Essentially, a big part of it is the hormonal regulation. So risk factors. Go. Woman,
Petite.
petite, older, Caucasian,
Not enough calcium.
not enough calcium in the diet,
Less exercise.
less exercise, so sedentary lifestyle,
Alcohol,
alcohol, carbonated drinks,
Smoking.
smoking, which actually pictures, if you think about this, older Caucasian petite woman who drinks alcohol with Diet Coke or not Diet Coke and smokes, that's pretty badass picture. Drugs. What can make men more susceptible to this disease? Think about this. So why, in the first place, why men are not as susceptible? Hmm? Testosterone doesn't stop being produced. So, go ahead. What can make men more susceptible?
Being fat.
Huh? Not just cancer. Something, what is you, so drugs that treat prostate cancer, what do they inhibit? Yes, androgens including testosterone. So when androgen levels, including testosterone, start to decline rapidly, men will develop osteoporosis. Does that make sense? Okay. We discussed this. Remember our discussion why U.S. elderly population is more susceptible to the fractures? Less active. More sedentary lifestyle. The best thing about drive-through, in Louisiana, they were selling drive-through daiquiris, a cocktail, in a plastic cup.
Oh, yeah. Yeah, like New Orleans and stuff.
Oh, yeah, everywhere. So you can drive, you can buy alcoholic drink, put it in a cup holder,
I hear they make them really strong, too.
which scares the shit out of me. Pizzettes disease. So in this case, what you have to understand, the only thing that I ask about Pizzettes disease is that it's haphazard deposition and resorption of the bone. It's like, think remodeling, but you hire people to say, replace the roof. How long does it take? I don't know, like maybe 3-4 days, professional team. They do it in 2 hours. And quality is relevant, So that's pretty much it. Prevention strategies to avoid osteoporosis. There's one answer.
Don't drink alcohol.
Exercise. No, I mean, you can drink a little bit, okay, but exercise. So weight, not just exercise, weight-bearing exercise, that's important. Specifically, weight-bearing, resistance training, okay? Treatments. Denosumab, biphosphonates, hormone replacing therapy. Hormone replacing therapy, when women start to take estrogen analogs that stimulate estrogen receptors everywhere. What's the problem?
Estrogen can cause cardiac problems.
Cancer. 2 types of cancer that are very common in females, pretty much only females, breast and ovarian cancer. Several types of breast and ovarian cancer called estrogen dependent. High levels of estrogen stimulate estrogen receptors, and I don't know the exact biochemical mechanism, but stimulation of estrogen receptors leads to the cancer development. It's like special type of cancer, estrogen dependent. So if you will start to give estrogen after the menopause, it's going to be estrogen higher than normal, because after the menopause, normal is very low, which may promote the development of ovarian and breast cancer. Biphosphonate stimulates the apoptosis of osteoclasts. Denosumab blocks the activation of osteoclasts by inhibiting rank L. Estrogen receptor agonist. Now that's a funny thing. There are drugs that stimulate estrogen receptor on the osteoblasts, but not in the ovary or breast tissue. That makes sense? No?
I did that also.
Okay. So what you can do? First, you can work through estrogen. You can give estrogen to females. Is it going to work for bones? Yes. But the problem is that it's also going to stimulate, may stimulate development of cancer in ovaries and in the breast. Good? Is that understood? You can kill osteoclasts by phosphonates. They stimulate apoptosis. So resorption of the bone doesn't happen. Or you can block the activation of osteoclasts by inhibiting the specific molecule. That makes sense?
Yes.
Now, receptor agonists. If you can create a molecule that activates estrogen receptors on the osteoblasts only, not affecting breasts or ovaries, then you can increase bone deposition without stimulating potential cancer development. Clear?
And we have drugs that can specifically target that?
Yep.
Huh.
Skeletal growth stops females 18, males 21, 25. Babies born not with the cartilaginous skeleton, it's largely bony. Bone density, at least partly genetic, yes, at least partly. Joints, two bones together. Joint function, bone connection, holding skeleton together and ensuring mobility. Three types of joints based on mobility. I want to hear it from you. Syn, arthrosis, amphi, arthrosis, diarthrosis. Synarthrosis are immobile. Amphiarthrosis are slightly mobile. Diarthrosis are fully mobile. Okay? Three types of joints based on their structure. Fibrous, cartilaginous, synovial. Three types of fibrous joints. We have sutures, we have syndesmosis, and we have gymphosis. Sutures are only in the skull. Syndesmosis, ligaments connecting joint ends like interosseous membrane here. Gymphosis is exclusively teeth, the jaw. Okay. Are they movable? Sutures and gymphosis aren't. Syndesmosis can be. Partially movable. We're not talking about diarthrotic joints. Cartilaginous joints. Synchondrosis, rib, sternum, costal cartilage. Symphysis. Symphysis joints are slightly movable, so they are amphiarthrotic. Synchondrosis are usually immovable joints. Synovial joints. Let's think about structural features. What is ends of the bone in the joint are covered with what type of cartilage? Hyaline. It's called articular, right? Articular cartilage, which is hyaline. Very good. The joint is filled with synovial fluid, which is that viscous, lubricates the ends of the bone and also nourishes the cartilage, right? The synovial fluid is produced by synovial membrane and fills up the synovial cavity. Synovial membrane is the inner layer of the joint capsule. The outer layer of the synovial capsule is external fibrous layer, right? Often there are ligaments that stabilize the joint. Okay, ligaments that stabilize the joint can be extracapsular, outside of the capsule, capsular, and intracapsular. Some synovial joints have fatty pads for cushioning. Some of them have bursae that work like bearings to reduce the friction between the ligaments or muscle tendons in the bone. And some of them have tendon sheaths. It's like really large bursae that surround tendons and also reduce bearings. So that's, we kind of got this one. Stabilization of synovial joint. You have to know, what's the least important factor? Shape of the bone ends. What's the second? Ligaments. And the most important factor is muscle tendons and strength of the muscles. Bless you. 6 types of the synovial joints. Let's go. Huh? That's pivot, ball and socket, hinge, condylar, saddle, plane. So, axis. Plane. Is there any axis? Non-axial. Hinge. Uniaxial. Pivot. Uniaxial. Condylar and saddle. Biaxial. Ball and socket. Multi-axial. Got it? There's a table. Know that. There will be questions about it. Okay. Okay, quickly. Movements. Gliding. Flexion. Extension. Hyperextension. Flexion, extension, hyperextension. So flexion and extension happens in the sagittal plane and transverse plane. Okay? Abduction, adduction, circumduction, rotation, supination, pronation, elevation, depression, protraction, retraction, opposition, dorsiflexion, the crane style, protecting dorks since 1984.
Wait, isn't it backwards? Isn't
Okay, that's dorsiflexion. That is Plantar flexion. I don't know if you can see me.
Oh, let's rotate it to that. Say, I'm sorry.
I'm practically risking my life here.
I can't remember what it's called.
Can you see my feet?
Yeah.
Inversion. Eversion. I think we covered everything. All the moves. Okay? Know the planes because planes really help. Okay? Now, when I say, I'm not going to ask you which joints can pronate and supinate, which joint such and such. It's going to be more in the line of when you do something like this, like those two lousy questions that were in the quiz. When you do something like, what kind of movements do you produce? Okay, and you have to pick whether it's flexion or abduction or something like that. Okay? Okay, I got this. How many joints are in the knee? There are 3 major joints, right? Medial and lateral tibiofemoral and patellofemoral joints. Movements, flexion and extension, and a little bit of rotation. 3 ligaments that largely form the joint capsule. You have patellar ligament, you have patellar retinacula. Yeah, well, there's more than 3 actually. Collateral tibial, collateral fibular ligament. On the posterior part, there is the arcuate popliteal ligament and oblique popliteal ligament. Muscle tendons that reinforce the joint. Quadriceps tendon is the most important reinforcer. Okay? Role for menisci. They improve fit. How many menisci are in the joint? One joint. One joint. In one joint. No, in 2 legs, there are 4. In 1 leg, there's 2. We good? I understand. When you said 4, I realized what you were talking about. Which ligaments prevent the hyperextension of the knee? It's collateral ligaments. Tibial and fibular. Okay? Does that make sense? Which prevent the anterior and posterior displacement, the ones that torn often. 2 cruciate ligaments. Anterior and posterior cruciate ligaments. Question? Anterior and posterior cruciate ligaments are intracapsular. What damages when knee experiences the lateral blow? First, so lateral blow. What's going to be torn first? Tibial collateral ligament, then cruciate ligaments, and then meniscus. Does that make sense? You can think like this. They have tri-C. Collateral, cruciate, cartilage. Shoulder joint. Type. Ball and socket. Movements. A lot. Okay. Even rotation to some extent. Is it stable? No. But it's very movable. 2 major reinforcing ligaments. Coracohumeral and glenohumeral ligaments. Are they good? They aren't, because glenohumeral are often not there. Major muscles. Now, what you need to know about major muscles that stabilize the shoulder joint? biceps brachii, and rotator cuff muscles. That is it. Elbow joint, hinge, movements, flexion, extension, 3 ligaments that reinforce elbow joint, radial collateral, ulnar collateral, and annular ligament, muscle tendons, flexors and extensors of the wrist, surprisingly, because they run from the humerus across the wrist. Hip joint, ball and socket, movements, abduction, adduction, flexion, extension, hyperextension, circumduction, more stable than shoulder joint, but less movable. 4 ligaments, pubofemoral, iliofemoral, ischiofemoral ligaments, and ligamentum teres. Muscle tendons. When I say muscle tendons, you got to think about muscles. So muscles is going to be abductors, muscles that are responsible for the hip movements, practically all of them. Extensors and flexors, adductors and abductors of the knee. Oh, not the knee, the hip, of course, I'm sorry. So muscles responsible for hip movements. Okay? Flexors, extensors, abductors, adductors. Acetabular labrum is the little ridge around acetabulum that provides an additional depth to the acetabulum and stabilizes the joint. Temporomandibular joint, you have hinge joint and gliding joint. Okay? It's the most easily dislocated joint in the human body. Why cartilage and ligaments repair slowly? Not vascularized. It's the main method for treatment of cartilage tears. Well, replacement, removal of the fragments, and maybe wait till it heals. If the cartilage is totally gone, you can try to replace it. It doesn't work terribly well, but there are some examples of meniscus transplant, especially in the youth. If meniscus is gone, what happens to the knee joint? What's going to happen? What's going to rub against each other? Bone ends, right? What's going to happen to the cartilage? It will become wear away. Bone ends will be exposed to each other. Will start to get inflamed due to the damage, start to grow, and eventually the bones may fuse. That condition is called osteoarthritis. Very, very good. Sprain. Tear of cartilage. Tear of ligament, sorry. Tear of ligament can be treated by reduction, stitching them back together, or replacement. Does that make sense? 3 approaches. Why can ligaments be transplanted with a relatively low risk of rejection? What is the reason? They are poorly vascularized. Luxation, bones out of alignment. Luxation is often accompanied by sprains. Treatment options: put it back together and give some ibuprofen. Subluxation is partial dislocation of the joint. Bursitis, inflammation of bursae, usually due to the mechanical pressure. Tendinitis, inflammation of the tendon, okay, usually due to the overwear. Treatment options: anti-inflammatory. For tendinitis, may also be surgical. Arthritis. Can you define arthritis in general in one statement? Inflammatory degenerative condition affecting the joints. We have osteoarthritis, rheumatoid arthritis, and gouty arthritis. Common symptoms: painful movements, swelling of the joints, loss of mobility. Osteoarthritis. Normal wear and tear causes it. Associated with age, develops in elderly. Cartilage is worn out. Joint ends start to rub against each other and become thicker and thicker. Treatment options: mobility, pain medications. Okay? Chondroitin or glucosamine, not effective. Rheumatoid arthritis, anti-inflammatory disease. Okay? Basic mechanism: your own immune cells attack synovial membrane. Synovial membrane becomes inflamed and forms pannus. Okay? Pannus grows, enlarges. Inflammation in the joint leads to the formation of connective tissue between the bone ends. Connective tissue ossifies, which is called ankylosis. Okay? At this point, bone becomes immovable. Is it curable? No, not curable, but it's treatable. Gouty arthritis is more common in men, characterized by the deposition of uric acid in the joint. If disease is not treated, it also leads to the ankylosis. Prevention and treatment: there are some drugs, but water, no alcohol. Lyme disease, infectious disease caused by bacteria. That's all you need to know. Transmission route: tick, yes. Symptoms: joint pain and erythema migrans. Treatment options: antibiotics. Is it curable? Oh yeah. If you treat it early, oh yeah, it's totally curable. If you delay, oh yeah, then it can become chronic and it's pain in the ass to treat. Any questions?
There's a test to see if anybody has a Lyme,
Oh yeah.
even if it's delayed.
Oh yeah.